I'm going to keep it really short so we could stay on time. Most of the information was already shared in previous presentations over the last couple of days. I found this publication by the group here, which to me is basically the essence of what we need to do to understand outcomes in patients with SCAD. The important message from this publication is that really following the natural history of spontaneous coronary artery dissections and trying to look at what happens if we really do not intervene and how patients do. So I'm just going to run through this small cohort of about 182 contiguous patients who were followed for about a median of 150 days. Of these patients, what was observed that in about 150 days, 86% have spontaneously healed without any intervention. And at 30 days post-SCAD, there were about 95% that had complete healing. I think this is important because as an interventional cardiologist, you always want to do something and intervene and fix, but learning that just waiting as long as there is no major damage to the heart muscle is probably better. So the big question is to stent or not to stent, conservative versus PCI in SCAD patients, and how do they do? And really the data is quite reassuring from multiple registries that we've already seen this data yesterday presented by Jackie, that in about 6 months follow-up, 100% of conservatively managed SCAD was healed, and in this particular study from Vancouver, at 154 days, about 86% of the lesions were healed. So what I learned from this is that when I see my patients in SCAD clinic, it's really important to share this information and present to them that even if they did not get a stent, there is a high chance of them by about 150 days to 6 months to have complete healing. And this is the guidance I have as far as follow-ups, and if there's residual chest pain, doing more ischemia testing. When we talked about stenting yesterday, Dr. Trammell and Dr. So showed that really stenting is very challenging. There are a lot of issues regarding the proper sizing of the stents, which you can see here in this analysis could sometimes lead to 5–6% stent thrombosis. I like the algorithm that was presented in this paper as a guidance of how to manage and what the outcomes would be, expecting, again, full healing in about 86% to 95% of patients. Again, going back to the SCAD cohort, CanSCAD, we saw in this cohort that patients who presented with SCAD, 86% of them had conservative management and did really well. And the residual cohort received some type of revascularization. We also learned that fibrinolysis probably is not a good idea, although if we are not sure that we're dealing with SCAD and we have ST elevation, giving fibrinolytic is not completely wrong as a way of trying to reperfuse the patients. So overall, the outcomes of the CanSCAD showed major adverse events of about 8.8% in hospital, and of those, as you can see here, very low rates of death, 0.1%. I really want to emphasize that to the patients and the audience, that really, when we look at the big picture, having a SCAD is a devastating event, but when you look at the big picture of it, if managed properly and if there are no major initial events, patients do really well, and we'll look at the 30-day outcomes. The big concern always is the manipulation of SCAD, recurrent MI at 4%, and of those, you can see that the big challenges come with extension of the SCAD. iatrogenic dissection when we do the angiograms, and ventricular tachycardia or abnormal arrhythmias are only in very small percentage, about 4% in hospital. At 30 days, again, very low rates of death, 0, with recurrent MI of about 2.1%. Overall, the recurrent MI is probably the highest driving outcome in the adverse events at 6.1%, and of those, unplanned revascularization of 3% and congestive heart failure of 0.4%. The most important factor that played a role in adverse events was the peripartum state, and we saw that patients who are in a peripartum state had the highest risk presentations and probably worse outcomes compared to other patients. There isn't that much out there as far as long-term outcomes. As you can see, there's a lot of effort made to collect data and to have longitudinal follow-up in patients with SCAD. Again, we don't have randomized trials to compare to types of therapies and how this would reduce adverse events and reduce negative outcomes. But in this cohort, again, from the group here in Vancouver, the MACE rate at 3.1 years of follow-up was 19.9%, and of those, the myocardial infarction was 16.8%, with recurrent SCAD 10% at the follow-up time. Revascularization was 5.8%. The authors defined 2 factors that will reduce events, and this is the use of beta blockers in patients who were identified with SCAD, and also treatment of hypertension. And you can see here in the Kaplan-Meier curves for both the beta blocker treatment, survival-free of SCAD, and reduction of recurrence of SCAD, and also proper control of hypertension as a risk factor. SCAD in-hospital rates are relatively low from what we saw from these cohorts presented, and PCI success rate varies depending on the different studies that we see, between 64 to 91%. We've already explored the challenges and why doing PCI in SCAD is difficult and may lead to partial success. Conservative management is the first choice in treatment unless high-risk features are identified, and I would follow the algorithm for that. And the natural progression of SCAD is really healing on its own, with 95% healed at about the follow-up time that we saw in the trials. Recurrent SCAD rates are reported for up to 30% in the follow-up between 4 to 10 years. And in recurrent SCAD, the vast majority of adverse events are recurrent MI, and they are not related to PCI. Recurrent MI at 30 days and up to 3 years in follow-up is 4 to 6%, and the recurrent de novo SCAD is 2.8%. I know that these are a lot of numbers to remember, but I think it's important for us to have a little handout in our SCAD clinics when we see our patients, to just give them these particular numbers and reassure them that really the importance of knowing that being diagnosed with SCAD is to a point where you know that there are certain factors that could prevent the reoccurrence, and try to answer the questions. How does SCAD compare to the usual coronary artery disease ACS outcomes? To stent or not to stent, decision made based on high-risk features, whether to re-angio or not. I would again say most patients heal well, and if they have residual symptoms, maybe it's good to start with non-invasive testing rather than going straight to an angiogram. And participation in cardiac rehab program and proper medical management with beta blockers and hypertension control show improved outcomes in the SCAD population. Recurrent chest pain Is it another MI or is it healing? Again, a lot of questions and a lot of work for us as practitioners to learn and motivate us to enroll patients in registries and start introducing more different interventions, including cardiac rehab. And I believe mindfulness, relaxation techniques would also be something to test. Thank you.